welcome to Transfusion Practitioners across the world, podcasts for TPs and other transfusion professionals to talk all things blood transfusion.
Hello everyone, my name is Jana. I'm a transfusion practitioner in the University Hospital of Brussels in Belgium. And I also work for the Belgian health authorities. And there I help to improve the transfusion practices in the Belgian hospitals. And in fact, we also try to implement patient blood management with them. And so I have been doing this since 11 years, and my educational background is midwifery. So I welcome you to this ISBT podcast for transfusion practitioners around the world. TPs have expertise in many different clinical specialties. So for this episode and our next 3 episodes, we are talking to transfusion practitioners working in some of these specialist areas. So today's episode is about transfusion in obstetric care. During pregnancy, it's common for women to develop iron deficiency and anemia, and this can continue into the post-period period. Anemia and iron deficiency represent significant health problems in women of reproductive age, and it's estimated that in 2011, 38% of pregnant women worldwide were anemic. Also, where a mother is RhD negative and a baby is RhD positive, the mother may develop antibodies to the baby's red cells, which can lead to hemolytic disease of the newborn. And to prevent RhD immunoglobulin, it's used during pregnancy, but this can also lead to problems, especially relating to administration issues. And finally, bleeding during childbirth, particularly peripartum and postpartum hemorrhages, pose a significant risk for many women, and transfusion is critical to support mother and child in these situations. During all these topics, we will also consider patient blood management, of course, and how some of the principles can be applied to obstetric care. We are very fortunate to be able to bring you this podcast thanks to the support from the International Society of Blood Transfusion, known as ISBT. ISBT is a global community of professionals sharing knowledge to enhance transfusion practice and the blood management. The society does this providing opportunities for advancing knowledge and education and by advocacy for the welfare of blood donors and patients. ISBT has many working groups that focus on specific topics or area of practice, and one of those is the Transfusion Practitioners subgroup. If you are not sure what transfusion practitioners are, you may want to go back and listen to our first podcast about what is a transfusion practitioner. So now we are going to meet our guests for this podcast. We are having a conversation about obstetrics and transfusion with colleagues from both Australia and the UK. So Chelsea Anderson is a midwife from Australia with a special interest in transfusion. Chelsea, please can you introduce yourself and give us a summary of how you got to your current role?
Thank you, Jana. My name is Chelsea Anderson. I am the midwife manager for maternity and newborn services in Far West Local Health District. So that's in New South Wales in Australia. I live and work in a rural and remote town called Broken Hill, and that is on the opposite side of New South Wales to where Sydney is. My journey into blood transfusion management happened soon after high school when I started a Bachelor of Medical Science in 2005, and I did not finish it, but I did go into work as a pathology lab assistant in the local hospital from about 2007 until about 2012, 2013, when I became a midwife. So my role in transfusion came about from being a midwifery lead on the blood management committee for the hospital and for the local health district. and then I soon became the lead for that blood management committee. So as a midwife and as the lead for blood management, I cover blood management policy, administration, incidents, best practice, liaising with our state stakeholders as well, and working with other critical care clinicians as well as midwives. So that's how I can blend blood transfusion and maternity together.
Thanks, Chelsea. That's very interesting. Pascal Winter is a transfusion practitioner in the UK. So, Pascal, please can you introduce yourself and give us a summary of how you got to your current role?
Morning, Jana. Thank you very much. Yes, my name is Pascal Winter. I'm the lead transfusion practitioner at a hospital in East London, in Essex, actually, so called Barking in Havering. So my journey has been quite interesting. Personally, for me, I used to. So my background is nursing, but I've also worked in a bone marrow transplant unit for a very long time. Always fascinated with blood. And so, as you can imagine, with bone marrow transplant, there's always transfusion involved. And then I got invited to, actually, I was asked to join the transfusion practitioner role some years ago, and that's how I got into it. And so I used to work in a leading hospital, teaching hospital in London. It's called Bath Health, where I manage trauma patient, obstetrics, and mostly all sort of major hemorrhages, but also anything related to transfusion. And in the last year and a half, I moved to my local hospital, which is Barking and Havering, a very busy hospital where we deliver about 8,000 babies a year. And it's always fascinating to see how things have improved and what we've learned from incident. And as you can imagine, there's with transfusion, there is the aspect of making sure we give safe transfusion, but also when it comes to obstetrics, there is that element of how how safe are we giving it, but also you've got the antibodies, you've got to think about all the RH, all the potential risks that can happen with transfusion. So that's quite interesting. So I think it's a good way of actually sharing this information in this podcast. Thank you.
That's also very interesting. I'm sure this will be a great podcast. Thank you. So now to our discussion. The first topic we are going to discuss is anemia during pregnancy. Lecture highlights that there is a high prevalence of iron deficiency and anemia during pregnancy and postpartum. So starting with Chelsea and then Pascal, please can you talk about how iron deficiency and anemia are managed in pregnancy, including IV iron services if you have one or if you would like one?
Thank you. So in Australia, midwives and maternity clinicians, we screen all women for anemia early in their pregnancy. So we screen for ferritin early in their pregnancy, and then around the middle of the second trimester, around that 28-week mark. Where I live and work, we are really fortunate to have a continuity of midwifery programs called a midwifery group practice. And we have a known midwife who can then make sure that results are checked and followed up and actioned, which just really prevents any women slipping through the cracks, so to speak, if they are anemic. We then can use oral iron supplements to, help supplement women's hemoglobin, particularly if it's iron anemia. And we can then also use IV iron in case that's needed as well. Australia have a really lovely flowchart produced by Lifeblood, and that is really helpful to be able to work out if women maybe should be more suitable for oral iron or if they meet a criteria for IV iron. So even in Broken Hill, in our small maternity unit in the outback, we can still get access to IV iron, and women can come in and access that treatment. So we're really fortunate.
Thank you. I think to add to this, so where in my hospital we also have an iron service, but before we get to that, yes, we do have a lot of women that are iron deficient, anemic, and we go with the the reference from Trans in 2020, where in the first trimester, if your hemoglobin is 110 gram per liter, we would say that you're iron deficient anemia. And in the second trimester, it'll be 105 gram per liter. And if it's in the third trimester, it will be 100 gram per liter. And again, that's postpartum as well. So we go on that definition, and what we have set up in the hospital, that we would screen those patients, and we do look at their ferritin level, we look at folate and B12 and so on. And so we previously were having IV iron infusion, mostly on the antenatal wards. But what we have found is oftentimes they were not getting their IV iron in time, or they were missed, or it was a bit too late to give them. We set up an IV iron clinic in 2014, about 10 years ago. And this service, we were meant to be looking at 8 patients a week. And as you can imagine, this has expanded so much. Now we see about 50 patients a week, which is quite significant. And we are probably the envy of most trusts in London, because the service works really well. And what we tend to do, we have a very slick process where we have 2 things. We have the first one is we've got the midwives that would be screening those patients, and then they would refer those patients to us quite early, and then we would screen them, and then we would also give them we would have a prescription and so on by our consultant, and then we give them IV iron in clinic. But we've gone a bit further. We also develop our nurses to be able to work under a PGD, a patient group directive, where they can prescribe IV iron, and then they can administer it in clinic. And that's worked really well, because obviously we are offloading the workload of medics, so which means then we can see those patients early, and then we can provide them iron. But what we don't do is we don't keep on following them in terms of management of care, but we just make sure they get the IV iron. And this is very, very helpful for our patient, because we get great rating from them, saying this has made their life a lot easier. They don't need to come to the hospital directly. They just go to as a rapid clinic, and then it works really well. Now, my plan obviously is to try to expand this and really celebrate this, first of all, but also to make sure that we give appropriate care to a patient rather than giving them transfusion. And we are currently doing an audit looking at how many patients we have, or how many admission we've prevented in hospital, but also how many patients where we appropriately give iron infusion instead of giving them transfusion in hospital. As you are fully aware, oftentimes doctors and we tend to jump on giving transfusion, thinking that is the right way, but not really doing the full investigation. So I think it's good to look at this audit and look at how many we've prevented inappropriate transfusion, but also we've managed their anemia appropriately. Yeah, thank you.
That's very interesting. It's nice to hear, or it's obvious that, as always, coordination, multidisciplinary communication, and also auditing is key in a good success. So up to our next question. Many women are transfused postpartum for anemia before they are discharged home. As a patient blood management strategy, some centers are looking at a single unit transfusion system for these women. Is this something you're familiar with, or do you think do you think this could work in your areas?
Thank you, Jana. I can answer that one. And I'm sure Pascal can support this as well. So yes, Australia does have a single unit blood transfusion policy, which is about getting the right women for the right product at the right time. So as Pascal mentioned in the question 1, sometimes iron IV is more appropriate post-birth than blood, particularly if the woman isn't actively bleeding or she's not symptomatic of anemia. So I guess first things first, as midwives, we are also now more, we're weighing soiled linen much more often now. So we're really getting a more accurate measure of the amount of blood that a woman has lost. So that's really given us an accurate estimated blood loss. And then together with the hemoglobin, as well as any symptoms of anemia, we can then use a guide that's, the hemoglobin normally needs to be below 70 grams per litre, and then also be symptomatic of anemia to have a single unit of blood transfused, and then assessing that woman before a second unit is ordered by the doctor as well. Pascal?
Yeah, we have pretty much a similar approach here. We have a very much restrictive transfusion. And I think I kind of want to bring this here. So it's good. I've worked in two trusts where you have a hospital where you have what we call remote electronic issue, where anyone could go to remote fridge and get the units. And that tend to be quite liberal, which means there's less control over these type of sort of system. Whereas where I'm currently working, all the units are issued from the laboratory. So there's a bit more control over how many units you're issuing out. But we also have introduced a single unit policy, which works really well. And one of the things we do when we have a major hemorrhage, during core hours, our transfusion practitioner actually attends the call and goes to the obstetric hemorrhage and almost coordinate the transfusion. So, which means then if people are deciding to order blood, we can, or asking us more blood, we can, one, make sure we got a balance for hemostasis, i.e. making sure we got the right plasma balance ratio, but also that we are keeping tab of how many units they are ordering, while we are also managing and looking at the laboratory numbers following blood tests. So that's one. And the second thing that we do as well is around making sure that the tests that are being done throughout the major obstetric hemorrhage is being done as well. So you've got that coordination, which really allows you to determine whether you should be giving more blood or not. And what I have introduced recently is a tag from elastography, which also allows us to decide whether we should be giving transfusion and what component you should be administering to a patient. So this is quite a fairly project that I've implemented since February. So still a bit of work needs to be done, but I think it's a starting point. In terms of looking at how the patient was managed afterwards, we have also a group called a PPH panel, or postpartum hemorrhage panel, where we would review all transfusion that's happened during major. So anybody who's bled over 2 liters, we would have a meeting, the PPH panel, and we would review the appropriateness of all the transfusion. And there will be some learning. Now, as a standard, if anyone has had a transfusion, it will be considered as a sort of low level of harm because you've actually given them blood. But we will be looking also whether at that point what contributed to the major hemorrhage, whether they had any condition, was there anything placenta previa, what was actually potential risk of them bleeding more, and so on. And if the transfusion is appropriate, then we'll be grading them as well. And we'll be looking as well the flow of what happened. We do have a great system called K2 system. I don't know if you're used to this. It's a very I love this system because it's well documented is about what happened to the woman throughout the delivery period. And the midwives are very good at documenting of what's happened and at each stage whether tranexamic acid was given and how many units they received, and looking at whether hemoglobin was checked after each unit. And it's quite difficult in a major hemorrhage because obviously you're dealing with two things. You're trying to make sure that you're reducing the bleeding, but at the same time you've got to look at is that or you look at the numbers, but also are you treating both the number and also the patient? So it's quite an interesting process. But I feel having having this particular group afterwards and reviewing whether there's been whether we're deviating from our normal procedures in terms of our major obstetric policy, or have we followed them and given the appropriate treatment to the patient is very helpful. So if there's anything, what I would advise most people to do is to introduce a postpartum hemorrhage panel on a monthly basis to review your hemorrhages. Thank you.
Thank you. That's very interesting. We will talk later also about peripartum hemorrhage. So moving on to the management of prophylactic anti-D immunoglobulin. SHOT reports in the UK. SHOT is Serious Hazards of Transfusion, which is a UK hemovigilance scheme. So they have shown that administration errors in anti-D immunoglobulin are quite common. My next question is in 3 parts. How does the RHD immunoglobulin process work at your organization? And do you audit the use of RHD immunoglobulins in RHD negative women? And if so, how do you collect the data and who is involved in giving feedback to the obstetricians and midwives? And thirdly, do you collect information on RHD immunoglobulin administration errors? And if so, how is it done? So this time we will start with Pascal. So please go ahead.
Yeah, I think it is something that is a big topic for us transfusion practitioners. Yes, we do administer anti-D to our patient that are RHD negative, but I think there's been ongoing learning about who should be getting anti-D, and we've had mistakes, errors have been happening from both sides in the clinical area where it was missed or was delayed, or we've had incident where patient was meant to be having anti-D, was not meant to be having anti-D, but clinical team called the laboratory insisting for anti-D, and then laboratory will be releasing anti-D. Patient then will be getting inappropriate anti-D. But also you have patient that's been sensitized and then anti-D will release as well. So yes, we still have some of the issues, and all these incidents are reported internally within our governance system, but we also report them to SHOT, and that with all the incidents I've just mentioned previously. Now, the process that we have in our hospital for the moment is we have women that we do the booking bloods, we assess whether they are RHD negative, and as soon as we detect that they are RHD negative, then this is highlighted to the midwives, and we make sure that they are aware that they should be given anti-D. But we also look at pre-fetal DNA testing to predict whether the fetus is likely to be positive. So there's an element of that as well. And we also make sure that the midwife knows the process of how to get the anti-D. Now, something I would like to kind of share with you, although we have all this knowledge and we have this process put in place, sometimes errors do happen. And what I've recently devised is a checklist for our clinical team, where it's what we call an interactive PDF. You put in all the details of the patient, but also you put the blood group of the mother, and you also put what will be the predicted, what we've come up as a predicted blood group of a fetus, i.e. RHD positive, and then it kind of allows you whether you should, it informs you whether you should be giving anti-D. In that particular checklist as well, it does have any potential sensitizing event, whether there's a bit of bleeding or whether they've had a bit of cell salvage and so on. We put that in there, so then it allows the midwives and the clinical team to know whether they should be administering anti-D. So, because what we've realized as well is, as much as you can have as many policies and guidelines out there, if people are not applying the knowledge in their practice, then this will be missed. And it's like a Swiss cheese. You can actually go and give anti-D inappropriately if people don't pick up these things. So the checklist now is allowing them to really focus on where anti-D should be given, and to prevent inappropriate administration of anti-D. Thank you.
Thank you, Pascal. And just adding to what you've already described, here in New South Wales, we've got a national guidelines around the prophylactic use of anti-D, which is really helpful, and they were only recently updated to include some of that really new and wonderful information about fetal DNA detection. So at the moment, that is available for women who have had a previous baby with hemolytic disease of the newborn, but we do expect to maybe see a bit more of that wonderful research coming into practice. I guess our practice at present, those women with a negative RH status, they are consented and given information early in pregnancy, and then offered the 625 international unit dose of anti-D at present at 28 weeks and at 34 weeks, and then postnatally if required with the baby. But when we're looking at auditing, we've got some really new and wonderful electronic databases, which will make this a bit easier to audit, less of a manual task. So definitely something to look into as well. And the same with you. If anything does go wrong, we'll pop it in the incident management system and then go from there. Thanks, Jana.
Thank you for these very useful tips, both of you. So our next topic is the peripartum hemorrhage, which we briefly discussed already a bit with Pascal. So this is a major concern worldwide. So I would like to ask you, how do you prepare your teams for this situation? Does your organization undertake simulation training, and what role do you have in this? Do you have top tips on how to create a successful simulation learning program on this topic? And to measure adherence to the massive hemorrhage protocol and patient outcomes, it's important to audit or follow up on some quality indicators. A transfusion practitioner or a midwife might play a role in the data collection and suggest some improvement actions, but active collaboration with a clinician is essential. So how do you deal with this need of multidisciplinary collaboration and medical leadership in your hospital? I would like to start with Chelsea for this one, if that's okay.
Thanks, Jana. In New South Wales, we have some really wonderful postpartum hemorrhage resources. So we've got some really wonderful policies and electronic modules that then come with some resources that we can deliver face-to-face training with. So my role is to help lead those scenario-based training, both for all maternity clinicians, so midwives, obstetricians, and nurses who come to assist us as well. I would certainly advise you to prepare when you are undertaking some simulation training. You can never over-plan, have all your resources ready. Make sure that your staff know how to access the background information, whether that's an online learning module or some equipment that you need to know how to use. I'm a big fan of the low fidelity simulation. I think the in the moment or the low fidelity equipment is really much, it's easier to facilitate rather than the wonderful sim mums that we all know exist as well. And I think once you've undertaken the simulation scenario around your postpartum hemorrhage, it's so important to debrief afterwards. The actual act of doing the simulation is a very small part. It's the preparation, making it really psychologically safe for everyone who's been a part of that simulation, and making sure that debriefing both with the team, and then if anyone needs some extra debrief. We've all been part of some big PPHs, and sometimes it can bring up some yucky memories, as well as, learning how to do better. So I guess my hot tips are preparation and planning, and then, yes, you're running the simulation, and then debriefing afterwards is so important. I guess when it comes to auditing patient outcomes, we've got it's called Quiz MatIQ, and that is a new database for New South Wales where we can track and trigger postpartum hemorrhage rates and benchmark ourselves against other likely sized maternity units as well as the state. So that's really helpful in using your data to analyse where you're at. and then working with the experts. So whether that's a clinical director or another clinical nurse consultant, or your stakeholders or the pathology lab, or maybe your governing body for wherever it is that you live, it's really helpful to be able to access those audit tools, know what you want to audit, and then know where you want to plan. So a recent project of mine was trying to identify not so much the blood and how it had been administered, but was it appropriately prescribed? And so it's taking that one step back and actually looking at the whole woman and her whole experience and like holistically, and working out, was she screened for anemia? If she did have blood, was it appropriate, etc. So just bringing all those together is really helpful.
Yes, thank you, Chelsea. This is really, really helpful. I think, it's something that I really would love to be able to introduce in my trust for simulation. And as you quite rightly said, it does take a lot of preparation. Again, in my previous trust, we did a lot of simulation for trauma, but we haven't done any for obstetrics. And it's so helpful to do those things because one, it's in a safe environment, but also it kind of build that memory muscle in a long run that you'll be doing this. Because we have a lot of deliveries of babies in my hospital, almost like there's a people would think there is a regular sort of simulation, so to speak, by doing on a daily basis having major hemorrhages. But if you've got the same people attending the hemorrhage on a regular basis, then other people might miss out. So you're absolutely right, having simulation and involving everybody, and again having somebody to watch what's going on, very helpful. And so that's the simulation. And for us, I think I've talked about this briefly earlier with regards to postpartum hemorrhage panel, where we review all our patients whether appropriate transfusion was given. Yes. But we also, just to kind of make it to share with you, on this panel, we have us, the transfusion practitioners. We also have the anaesthetist, we have the obstetrician and the consultant, but also we have a couple of midwives and our governance team for midwifery, and we go through whether every aspect of where we come in was it safe, was it appropriate, and we grade them as I mentioned. But we also tick at the bottom as well. We've got a checklist whether we've discharged a patient with iron oral tablet, and whether we think it was a safe practice that we operated under. And also we make sure we send them a letter. We send the patient a letter saying, sorry, you've had to have a transfusion, but we also inform them they can no longer donate blood, which I think is very helpful. So we try to encompass this into this PPH panel, and then we report this to our trust board. That's how we would do our PPH panel.
Thank you for that. I would love to ask you more questions, but unfortunately we are limited in time. So I would like to ask you, the Transfusion Committee, which may also be the Patient Blood Management Committee, plays a central role in quality management regarding transfusion practice and PBM. Are the topics we have covered in this podcast so far discussed during these meetings?
So for us, it's our Hospital Transfusion Committee, we call them. And yes, we discuss them, but I think that the focus tend to be in the other, postpartum hemorrhage, and that's where we discuss for our obstetrics. But if we had to look at other transfusion elsewhere and other major hemorrhage, that's probably not well addressed, and we tend to focus on those hemorrhages at the Hospital Transfusion Committee. Yeah, so not much to add on this particular area, but I think again I can speak on the behalf of a lot of my colleagues, especially in London, because I co-chair the London Transfusion TP group meeting, and we often say that our Hospital Transfusion Committee is not well attended, unfortunately. So which means then, I think I would say that most of the hemorrhage for obstetric tend to be discussed into the PPH panel. Thank you.
Just adding to what Pascal has just said as well. Similarly enough, the the specific obstetric use of blood is definitely mentioned in maternity safety and quality in your local health district, including at a state level, particularly around the use of anti-D as well. A lot of the clinical midwife consultants will discuss that. And the actual overarching use of blood and reviewing massive hemorrhage protocols, looking at they are looked at by the governing body. In my LHD, it's called the Drugs and Therapeutics Committee, but in the summer, the bigger local health districts, so they do have a patient blood management committee. Thanks, Jana.
Thank you. So I have a final question. We know that not all of our listeners have transfusion practitioners like Pascal or someone like Chelsea who leads on transfusion and PBM in such a way. Can you both outline the positive impact you think these roles bring to your obstetric care?
Sure, thank you. It's definitely given me a really bigger clinical picture of the whole of obstetric care. So it's really helpful in regards to even just knowing what type of blood tests to take and the importance of that pre-transfusion sampling. So I definitely think it's given me a bigger clinical picture and appreciation, as well as that critical care background. In midwifery, we don't tend to see a lot of critical care, but when it is critical, it's really critical. I also really love networking with the other experts, so whether that is critical care or pathology, or blood watch, and just even this podcast opportunity. That's pretty cool to be able to blend blood transfusion and pathology as well as midwifery and maternity care. So thank you.
I would definitely echo what Chelsea just said, and I think just to add to this, really, we have experienced quite a lot of difficulties in maternity when it comes to transfusion and major hemorrhage, but also there's been a lot of learning, and I think part of it, I'm glad I've been part of the part where you resolve those issues and try to make this safer for women to have safe delivery of babies. But also we learned there are other factors that could actually complicate delivery of babies, whether a health condition of the mum or something we didn't actually anticipate, whether it was placenta previa or some accretas and things like that. These are quite complicated situation, and there's a lot of learning. Although we've been delivering babies since the dawn of man, but it still remains that the risk that can be associated with delivery can be very high, and you learn something new on a daily basis, I would say. And it's about how us transfusion practitioners, we put this learning in our training and education for our teams so that they're aware and how to manage those patients to make this safe for the next generation of babies.
Thank you. This podcast really has been wonderful. Thank you for sharing your time and experiences with us. It's really beneficial to hear what a positive impact having these roles in place has to obstetric care. Thanks so much also to the listeners for joining us today. If you have any feedback, please use the questions linked with the podcast. And if you have further questions, you can link in with us by visiting the ISBT website and checking out the Clinical Transfusion Working Party, where you will find more details about Transfusion Practitioners subgroup. We look forward to having you join us for our next episode, where we will highlight the transfusion practitioner working with patients, families, and clinical staff in the pediatric setting. Until then, thanks for listening.